Hello, everybody. Am I audible and visible? I hope so. And hi, thank you for joining today's session and welcome to today's session on top papers in transplant infectious diseases, year 2022 and 2023. With the number of transplant grow, I think it is important for us to be aware and updated on transplant infections. And I think we are fortunate to have an expert in that area, Dr. Ankit Mittal sir, here with us today. And it's my pleasure to introduce you, sir. Sir has completed his MBBS from Kolkata Medical College and Hospitals and PG Diploma in Infectious Diseases and DM Infectious Diseases from AIMS Delhi and Fellowship in Transplant and Oncology ID from Toronto. Uh, Sir is a research enthusiast. He has published over 50 articles in national and international journals. He has authored around two chapters in books, and he has been a member of American Society of Transplantation as well as Clinical Society of Infectious Diseases. And he was a former ambassador for Royal Society of Tropical Medicine and Hygiene. He was awarded and has been acknowledged by multiple societies, and few of them are he was actually acknowledged by Bihar government for conducting training for healthcare professionals during COVID pandemic. And in 2023, he was awarded the best clinical science article by a new investigator, George Santos Award. And actually, sir is also a faculty at Marrow Super Speciality, if you're aware. And there was a recent it is actually available in YouTube and World Antimicrobial Awareness Week. During that period, sir has also there is a session in YouTube where sir has helped many people understand how do we interpret the cultures and resistant mechanisms. And I think it is very important and useful for practicing clinical pharmacists. Right now, sir works as an ID physician in AIG Hospitals, Hyderabad. He's an active person there, as well as he's an active person in antimicrobial stewardship program there. And I actually work there as a clinical research coordinator. And I feel lucky to be able to work with sir on a research program there. And yeah, sir is one of the most gentle and humble people. So with no further delay, I think we should get started with this. It is going to be a great learning opportunity. Over to you, sir.
Yep. Thanks, Amartya. I think you went a little overboard there, but thanks nonetheless. So first of all, thanks FCPI for giving me this opportunity to present, some of the top papers in transplant ID. So just wanting to make sure that I'm visible, like the slides are visible and my voice is clear, right? Okay.
Yes, sir. Yes.
Yeah, thanks. So what I've tried to undo is when we talk about transplant, we talk about both the solid organ transplant as well as hematopoietic stem cell transplant. And if we look at important papers, especially over the last 1.5 years, CMV is kind of the star of the show, where most papers, most research papers are directed towards CMV. And rightly so, because if you could take out n number of studies where they have looked at some or the other risk factors for adverse outcomes, be it in terms of graft survival, mortality, morbidity, anything, CMV will kind of figure out in those risk factors. So a lot of research these days have been focused on CMV. Unfortunately, most of the recent advances in the management of CMV, treatment related to CMV, is still not available in our country. So we are still mostly relying on one of the few medications like ganciclovir, valganciclovir, maybe foscarnet, cidofovir for management. But there's been some progress over the last 2 years, especially in the CMV management. So what I've tried to do is we have divided the session into two parts. First half, we look at hematopoietic stem cell transplant. I've tried to include papers that would, have some impact in our clinical practice, rather than being too futuristic or about things that are not available in the country right now. So talking about the first paper, which was again just published last year, is to assess the impact of colonization by multi-drug resistant bacteria in hematopoietic stem cell transplant patients and its impact on the clinical outcomes. So this was a single center retrospective cohort study. So what I'll try to do is for most of the papers, we'll try to divide it into a PICO format. So P is for patient or problem and intervention, comparator or comparison and outcome. So in this case, the patient population is the allo-HSCT group with post-transplant bacteremia. And what we are looking at is not in terms of intervention, but exposure is MDRO colonization and how they fare compared to patients without colonization with MDROs. And then outcome in terms of bloodstream infections, length of hospital stay, and overall survival. So all of us know that whoever is involved in patient care, everybody knows that multi-drug resistant organisms are becoming the nightmare of everyone. You perform a procedure, you do everything right, and then the patient succumbs to an infection in the post-transplant period. And increasingly, what we are doing is we are trying to now screen patients who are colonized with VRE, CRE, MRSA, and trying to isolate them, do decolonization, etc. But we still really don't know how it impacts the outcomes in terms of colonization alone. So this retrospective study, including 405 patients from all age group between 2015 and 2021, where they looked for screening with for VRE, MRSA, ESBL, and CRE. Most patients were neutropenic, and patients were on levofloxacin prophylaxis as per the protocol. And in case of febrile neutropenia, they would do empirical antibiotics based on the colonization status, and then as and when cultures became available, they would modify the treatment. Total follow-up was for 100 days or till hospital discharge. And colonization was checked between day minus 30 from the transplant to day plus 30 from the date of transplant. And then we, of course, looked at the overall survival with Kaplan, Mayer, etc. We'll not go into details since we have a lot of papers to discuss. Now, we looking at the results. Majority of the patients were male, adults, and had underwent allogeneic transplant instead of in addition to autologous. And 132 patients, that is 32.6% patients, were colonized with at least one MDR bacteria. And if we look at the distribution of the bacteria, so VRE was slightly low overall, but the major concern was with ESBL producing bacteria, followed by carbapenemase resistance and other carbapenemase producing bacteria. And if we look at the total number of colonization events, so in 132 patients, 181 colonization events were present, and almost more than 50%, almost 65% patients acquired the drug resistant organism colonization after admission and after HSCT, right? So this is something concerning because this is something that can be proactively prevented, not entirely, but to a great extent, yes, by following good infection control practices, etc. So this is something concerning that a majority of patients were not colonized at admission but get colonized post admission. Now, if you look at the cumulative incidence of positive blood culture on the y-axis and the days post-transplant, so the red line indicates the colonization status, whereas the black line indicates the absence of colonization. And overall, if we look, then the patients with colonization had a significantly higher incidence of blood culture positivity. So 36% compared to 20% with a significant difference. And if we break it down based on the type of organism, then ESBL colonization was also significantly associated with higher bacteremia. Same is true for carbapenemase producing Klebsiella pneumoniae. I mean, this is like 56% compared to 22%. And most of us who are involved in clinical care know that our centers or India as a country is a very high burden for carbapenemase producing organism. And in both the cases, like even if it's Kleb pneumoniae or other carbapenem resistant bacteria, the incidence of bacteremia is significantly higher in the colonized group. Now, in VRE, although the number is approximately double, like 50% compared to 25%, but only because 6 patients were there, this was not enough to achieve a statistical significance. But overall, higher incidence of positive blood cultures if you're colonized with any of the drug resistant organisms. Most, and this we can see even in the epidemiology of what kind of organisms were present, right? So in cases of non-colonized patients, we had Coagulase negative staph, which was the most common. Whereas in colonized patients, we had Klebsiella pneumoniae, either ESBL or carbapenem resistant in the colonized patients. And if you look at overall survival, if we compare it based on colonization status, although the overall survival was not significantly different between the two groups, but if you look at survival in patients colonized with carbapenemase producing Klebsiella pneumoniae versus non-colonized people, there was a significant difference in the probability of overall survival. And unfortunately, our population will mostly fall into this group where there's a very high incidence of carbapenemase producing Klebsiella pneumoniae, colonization or infection rates. This graph is showing based on the colonization status. And if you look at the probability of survival based on the positivity of blood culture, and if we compare MDR to non-MDR, although this is common knowledge that MDR organisms are associated with higher mortality rates, but there's a like a strikingly high incidence of mortality, which is calculated in terms of hazard ratio. So you see the hazard ratio in patients with MDR bacteria, blood culture positive, is almost 14, whereas it is 2.8. So it is like almost 6 to 7 times more likely that the people with MDR organisms will not survive as and when the time progresses. So this is something very, very concerning that I felt is very relevant to our practice. So that's why I wanted to highlight this, that there's an urgent need to collect our local and regional data, and colonization data can influence our empirical antibiotic choices, individualized antimicrobial stewardship practices. Now, antimicrobial stewardship in transplant setting is kind of very different from stewardship practices in general population. So there are lots of big centers who are coming up with pharmacists that are completely focusing on transplant patients, and there you have to be a little more lenient in terms of selection of antibiotics, duration of antibiotics, but it does not mean that you have to be unreasonable. So it does not mean that you have to allow everything, or if everything is justified just because a patient is transplant patient. Anyway, so we can individualize care in such patients, and with increasing evidence showing that decolonization practices are somewhat helpful, we can actually try and implement decolonization, look at how it is impacting the outcomes. And once a patient is colonized with MDR organisms, at least we can do some kind of prognostication to the patient, because it definitely impacts the overall survival in the post-transplant period. So that's our first paper. That was about colonization of drug-resistant organism in stem cell transplant. Now let's look at another important problem, that is duration of antimicrobial for gram-negative bacteremia in patients with neutropenia. Again, this is one population where this kind of an overuse of antibiotics. Now, a lot of times these patients are sick, and it's a very difficult call whether to start, stop, do what. But many a times you will come across a patient who had a febrile neutropenia. There's no particular focus. You have given some 7, 8, 10 days of antibiotics. The neutrophils have not recovered yet. And then there is a hesitancy to, de-escalate or switch back to prophylaxis, and considering that, that a 10-day course or maybe a 7-day course might be enough. So this paper again tries to look at that aspect, whether short course durations are inferior to, intermediate or long course duration. So same problem or patients are duration of antimicrobial therapy in GNB bacteremia and neutropenic fever. Intervention is the short course duration of antibiotics. Comparison is intermediate to long duration antibiotics. And they've looked at 90-day mortality and microbiological relapse. Microbiological relapse, as in the same bacteria, if it is causing another infection within the 90-day time frame. So we'll just quickly go ahead. But what I want to highlight is why are shorter regimens better? It's not, even if you just, try to overlook the part of preventing drug resistance, for example. because sometimes it is like the patient is too sick and all of that. But even then, shorter regimens can significantly lower the stay in the ICU, stay in the hospital, lower the cost of treatment, C. diff infection rates. Sometimes antibiotics might interfere with graft engraftment, etc. So it's not that giving an extended duration is going to be a very safe option, even if you are to overlook the increasing drug resistance burden. So we should try for the shortest but most appropriate duration of antibiotics. So this was a single center study retrospective design at Mayo Clinic, where they included all patients with neutropenia at the time of or within 24 hours of diagnosis of monomicrobial gram-negative bloodstream infection. So monomicrobial gram-negative bloodstream infection, and antimicrobial use was classified as short, intermediate, or long. So what we're trying to look at is 90-day mortality as well as 90-day relapse of same gram-negative bacteria. Again, using Kaplan-Meier method, these are standard statistical analysis methods when we are trying to assess mortality, risk factors, etc. So if you look at the total number of patients, 417, where 67 patients received a short course antibiotic, 81%, 67 patients short course, 81 patients in the intermediate course, and 58 patients received a prolonged course of antibiotics. And majority of the patients had a profound neutropenia. So inclusion is less than 1,000 neutrophil count, but profound neutropenia is less than 100 neutrophils at the time of enrollment. If you look at baseline characters, they were similar, except for if you see the hospital length of stay. So, since the patient is going to get extended duration of IV antibiotics, the duration of stay is going to be significantly longer, right? So, that is one difference. And if you look at the ICU length of stay also, it is significantly longer in patients who were on a longer duration of antibiotics. If we look at the microbiological profile, one thing I want to highlight here is in the intermediate and in the long duration therapy, you will see a slightly higher incidence of Pseudomonas infection. Probably that has led to a higher or a longer duration use of antibiotics in this group. But otherwise, if you compare the Enterobacteriaceae, it is kind of similar in all three groups. And if you look at the source of infection, intra-abdominal vascular catheter, these are the common sources as we also come across in our day-to-day practice. And total duration of antibiotics, by default, the short one is going to have a shorter duration. So the difference is almost like 2x. So patients who were on long duration received almost twice the duration of antibiotics compared to the shorter duration. And now looking at our outcome, that is mortality or microbiological relapse over a 90-day period, we see that uh, numerically, percentage-wise, it's slightly higher in patients who were on the, in the longer treatment duration, which might sound, counterproductive. The whole idea of giving a longer duration is based on the assumption that it is better, but apparently it's not that numerically. And if you look at your adjusted hazards ratio, then there's actually no significant difference, which means a short course of duration is as good as a long course duration, long duration of the course in terms of mortality and microbiological relapses at 90 days. But what is important to note here is whenever we are talking about these bacteremia, these are without any, obvious drainable source. For example, if it's like a abscess, intra-abdominal abscess with bacteremia. So in those cases, you don't go by duration that 8 days is enough or 10 days is enough. Then it is based on your improvement of the patient, drainage of the source, etc. But a lot of times, say if it is not based on any specific source, any deep-seated infection, in those cases, you can just treat it as a normal bacteremia as you would do in non-neutropenic patients. And once you have completed the treatment course, you can go back to a prophylactic approach just for neutropenic patients. So here also I'd like to highlight the role of transplant pharmacists, where they can help in ensuring that the duration of treatment is not unreasonably long, because it does not really impact the outcomes in these patients, but whereas it can increase the cost of care, duration of hospital stay, side effects, etc. So that's about the second paper. And like I said, duration is still guided by clinical response and not the typical number of days. So these are all to guide us, giving us a brief idea that, shorter is not worse as compared to longer duration. Now, so we have talked about bacteria in the first two papers. Now let's look at few of the important problems related to CMV. Now, as you know that for CMV prophylaxis, the Western countries are now moving towards letermovir. So letermovir is an antiviral which is now being commonly used in Western world where it is available as a prophylaxis for stem cell transplant recipients. But as of now, we don't really have the option of letermovir. So this paper tried to look at a similar problem where a high dose valacyclovir, if it could reduce the risk of CMV infection. So again, in the PICO format, we are comparing high dose valacyclovir to standard dose valacyclovir or preemptive CMV treatment. So preemptive CMV treatment, as in you follow the patients if there's a presence of viremia, that's when you start treatment. And treatment options are again something like valganciclovir, ganciclovir, or foscarnet, based on whatever is available. So letermovir prophylaxis is becoming the standard of care. Why not valganciclovir? Because valganciclovir can interfere with engraftment process. So transplant physicians really don't like valganciclovir in stem cell transplant recipients. But till letermovir becomes available, we need to have some strategies to prevent reactivation of CMV in this patient population. So this was again a retrospective study where they included high-risk CMV patients that were having CMV seropositivity and they were undergoing T cell depletion, haploidentical or umbilical cord stem cell transplant, which are usually at higher risk of having CMV. And then they monitored twice weekly CMV viral load till day 100. And they were followed for clinically significant CMV infection, which was defined as either viral load going above 400 or any CMV disease as per the investigator. Now, what is standard dose valacyclovir? So all patients in the post-transplant patients will receive standard dose valacyclovir to prevent from HSV reactivation. And what is high dose valacyclovir? It is 2 gram TDS, which is targeting prevention of CMV reactivation. Important to note that the medication doses have to be modified for renal dysfunction if it is present. So two groups, retrospectively, standard dose Vala versus high dose Vala. And what we are trying to look at is presence of CMV viremia or CMV disease. So 27 patients received standard dose valacyclovir and 35 received high dose valacyclovir. And if you look at incidence of any detectable CMV viremia, so universally almost like every patient in the standard dose group had some level of viremia, and it was lower 82% in the high dose group, and this was statistically significant. Cumulative incidence of CMV infection, clinically significant CMV infection, that is more than 400 or CMV disease, was significantly lower in the high dose valacyclovir group. Also, the median time to reactivation was much longer in high dose versus standard dose valacyclovir. And if you look at the cumulative incidence, there was a significant difference between the high dose and standard dose valacyclovir. Again, we'll just quickly move on. So overall, the impression is that until agents like letermovir are available, which are safe in the post-transplant period and effective, maybe we can try to use high-dose valacyclovir and but still continue to check the CMV viral load. In case of any breakthrough infection, the patient will need to go on to treatment doses of antiviral treatment. Next patient, treatment for first cytomegalovirus infection post hematopoietic stem cell transplant. So this was the Aurora trial. So like I said, valganciclovir is something which is known to cause bone marrow suppression, and you really don't want to, do it in the post-transplant period. So this is a new drug, maribavir, which is approved for treatment of refractory and resistant CMV. So this group of investigators thought of trying maribavir instead of valganciclovir whenever they detected a CMV infection in the post-transplant period. Now, again, since this drug is not available in our setting, I will quickly move with the study. Now, our basic assumption at a lot of times is that newer is better. So this paper kind of highlights that, even though the drug is newer, is effective in refractory resistant infections, probably it does not always mean that it will also be good as an upfront therapy. So in this phase 3 randomized multi-center trial, double blind, double dummy trial, they included all patients with over 16 years of age. And at the time of first documented asymptomatic CMV viremia, they started maribavir versus valganciclovir. So it was either 400 BID of maribavir or 900 mg BID of valganciclovir for 8 weeks, 1:1 randomization, and then they follow up for 12 weeks after treatment. Primary endpoint was clearance of CMV viremia, and secondary endpoint was absence of CMV disease at 8 weeks and 16 weeks. Also looked at treatment emergent adverse events. So if you look at, so the non-inferiority margin was set at 7%. And if you look at the difference overall, so yeah. So if you look at the overall incidence of or clearance of viremia at week 8, so it was around 69.6% in maribavir group and 77.4% in the valganciclovir group. So although it looks similarly efficacious, but the the what I tell you, the non-inferiority margin of 7% was not reached. So the lower bound of the confidence interval was greater than 7%, and they did all kinds of subgroup analysis and everything where they could not achieve the non-inferiority margin in terms of maribavir use for upfront treatment. And however, if we look at week 12, week 16, so it kind of reached that kind of significance. But the sample size is always calculated from our for our primary objective, which was for week 8, which it did not meet. But it looks like it is kind of effective in maintaining a similar proportion of viremia-free responders at the end of 8 to 16 weeks, right? So the other highlight of this paper was that there was resistance, so emergence of resistance in the treatment groups. So 8.8% patients in the maribavir group had emergence of resistance on treatment by week 8, and 14 patients had recurrence of viremia on maribavir treatment, whereas no patient treated with valganciclovir had a recurrence on treatment. Also, what is supposedly an advantage is the treatment emergent adverse event. So the adverse event was slightly better with maribavir, and the major advantage was a lower incidence of neutropenia in the treatment group. But overall, we still don't know if it is as good as valganciclovir in treating the episode of viremia in the post-transplant period. Even the GVHT incidence is kind of similar, slightly higher in maribavir, but there was no statistical difference. So maribavir did not meet the non-inferiority margin for primary outcome. Here, I would also like to highlight that the authors actually chose a very tight margin. Whenever you look at non-inferiority studies, they take something between 10, 15, 20%, and they chose 7%, which was fairly tight. And it still, although it did not meet the primary outcome at 8 weeks, but the activity was comparable at weeks 12, 16, and 20. What we are concerned about is the higher incidence of drug resistance and recurrence of viremia. And we don't want drug resistance to maribavir because it is already a reserved drug for refractory and resistant CMV infection. So this is something that we have to keep in mind. So once it becomes available, we have to be slightly cautious related to use of maribavir, but it might still be clinically relevant where you are seriously concerned about the myelotoxicity of valganciclovir. Right. Moving on to our next paper. Again, this is a recent advance. We'll move very quickly through this. So this is about treating lots of viral infections in the post-transplant period. So we keep talking about CMV, CMV, CMV because there's an antiviral treatment associated with it. But when we talk about viruses like adenovirus, BK virus, there's literally no treatment. You just hope that you reduce immunosuppression, which is easier said than done. And maybe you can try Cidofovir, IVIG, etc. But it really makes very little difference in the clinical practice. So, for refractory viral infections post stem cell transplant or viral infections for which there are no specific antiviral treatment, they compared a multivirus specific T cell. So these are virus specific T cells. What is special about posoleucel is it is off the shelf. So you don't have to do HLA matching for all of your patients. You can just purchase it and give it just like any other, granulocyte infusion. And you looked at clearance of viremia. Now, if we just briefly look at the issues related to post-transplant period, so as and when the level of host T cells decrease, the proportion of patients with single or multiple viruses significantly increases. So it goes up to 40 to 60, even more than 60%. And it is only after 4 to 6 weeks when the stem cell transplant derived T cells start to pick up that the viremia begins to clear. So this is the major area where we want to target and treat all the viral infections that are clinically relevant. So posoleucel is one such agent which targets six viral pathogens: adeno, BK, CMV, EBV, HHV6, and GC virus. So one T cell, one set of T cells that target all six viruses. So what they did is this was an open label single arm study where refractory viral infections were included, and they gave a single infusion of intravenous posoleucel. You could repeat the second infusion after 4 weeks, and then again at biweekly intervals. What they did is they also looked at interferon gamma response after transfusing the posoleucel. So at baseline, the patients did not have any interferon gamma response to the antigen or to the viral antigen. And after giving posoleucel, they checked for a virus-specific interferon gamma response. So out of 59 patients, total 59 patients with 70 infections. So there are few patients with multiple infections. You can look at the color coding. Each color denotes a different kind of virus. And you see that as time progressed, so 2, 4, and 6 weeks post transfusion of posoleucel, you see that there's a significant reduction in the viral load of the patients. And even if you look at the T cell response or interferon gamma response in the post infusion period, you see that for CMV, BKV, and adenovirus, there's a significant increase in the uh, interferon gamma response in the patient population. So this is a very promising, treatment option that might become standard of care in the years to come because it is easy to administer. It would be one dose. Maybe you repeat it after 4 weeks, and it works even against viruses where treatment options are not available. So this is a very exciting space to look out. Now, quickly, we have finished. I think we have done 30 minutes and we have spent 30 minutes on stem cell transplant patients and their problems. Now we'll move on to solid organ transplant related, some of the recent articles. And like last time, cytomegalovirus is going to remain the focus. But let's see. So first paper is clinical outcomes and risk factors for carbapenem resistant enterobacterial bloodstream infection in solid organ transplant recipients. Now, any discussion on any subgroup of patients in Indian settings is incomplete if we are really not addressing the problem of drug resistant gram negative bloodstream infection. So, like the first paper was related to stem cell transplants. So, here this is related to solid organ transplant. Now, again, PICO format, carbapenem resistant infections in SOT, that is our problem. The intervention and exposure is CRE bloodstream infection, which we are comparing to non-CRE bloodstream infection. And we are looking at graft failure as well as mortality rates in both the groups. Now, it is common knowledge that CRE infections are associated with high morbidity and mortality, and it leads to and long or multiple hospital admissions, because these patients are generally sick. For example, a CKD patient who's planned for a kidney transplant. That patient has multiple hospital exposure, either related to infections, dialysis, etc., has devices in place. a lot of things that can contribute or predispose to CRE colonization and infection. Risk of CRE is 5 times greater in solid organ transplant recipients than general population, and the clinical outcomes associated with this is not really well defined. So all of us know that it's high, the numbers are high, but how high is still something that we need to evaluate, and it needs to be evaluated on regional and local levels as well. And rates of graft failure and death range between 12 to 66% in these patients. So this was a multi-center retrospective study between 2005 and 2018, and you would be surprised with the number of patients they could actually include. If we were to do such a study spanning over 13 years, probably we'll have maybe 1,000 cases with carbapenem resistant, even more. So let's see. So they did a 13-year period multi-center retrospective study where they included all patients with positive blood cultures for Enterobacter sheep, and then they divided into carbapenem resistant and carbapenem non-carbapenem resistant groups. And then they did the case control design to determine risk factors for CRE infection. And the outcomes were mortality within 60 days of bloodstream infection and incidence of graft failure within 60 days of bloodstream infection. So 897 people over a 15-year period from 3 centers had Enterobacter sheep bloodstream infection, and only 70 cases were due to carbapenem resistance. Median age within the carbapenem resistant group was 56 years. Majority were men, and majority had received a liver transplant followed by kidney transplant. If you look at the source of bloodstream infection in most patients, it was genitourinary, followed biliary and lower respiratory tract, which was higher. Yeah. So it was higher in cases of non-carbapenem resistant group. Otherwise, Klebsiella, E. coli, and Enterobacter were the major pathogens in both the groups. The Enterobacter species was significantly higher in the carbapenem resistant population, as well as Klebsiella was the major organism in the carbapenem resistance population. And if you look at resistance to other drugs, so resistance to fluoroquinolone was very high in patients with carbapenem resistant infection, as well as around 7% polymyxin resistant in this group, whereas the resistance was low in general in the non-CRE group. And if you look at mortality at 60 days, patients with carbapenem resistant bloodstream infection had a 47% mortality compared to 12%, which was very, very significant difference between the two groups. And even if you look at the new onset graft dysfunction at 60 days, it was almost 3 times in the CRE BSI group. So very, very striking findings, because a lot of our patients who have carbapenem resistant bloodstream infection usually don't do well. Now, what is that exact number? I think it is upon us to evaluate at our respective centers how these patient populations are doing in general. And if we look at the all-cause mortality analysis, so they did a multivariate, univariate analysis just to find out which factors are associated with all-cause mortality and new onset graft failure. The majority contribution was because of carbapenem resistance infection, with an adjusted hazard ratio of 2.85 for all-cause mortality and 2.42 for new onset graft failure within 60 days of diagnosis. So highly relevant in our setting, given the very high prevalence of CRE, implementation of screening and decolonization protocols. Again, I mean, this is a very relevant topic that I feel is that we strictly, put into practice screening protocols and then decolonization protocols and see if these patients are doing any better than patients who don't undergo screening and decolonization. That is something that we should look at, because if we can prevent even one infection, that can improve the overall survival of this population. Now I'll move very quickly through 3 papers back to back, which are on CMV. Why we will not go into details is because, again, non-availability of the drug, but it might become available in the future, and And that is when we can use it in clinical practice from day one, actually. So first paper was recently published, Letermovir versus valganciclovir for prophylaxis of CMV in high-risk kidney transplant recipients. So high-risk kidney transplant recipient is usually D plus R minus, or say a R plus who has received ATG also. So that becomes a high-risk group. And the current practice is uniformly to use valganciclovir, although some centers are moving towards preemptive approach rather than prophylaxis. But prophylaxis remains the standard of care in most centers. And the duration could range between 190 days to 180 days or even longer, depending on the type of transplant it is. So Letermovir again is a standard of care in stem cell transplant recipients because of its safer myelotoxic profile. So that is why this group of investigators thought of comparing Letermovir as a prophylactic strategy in kidney transplant recipients. So here we look at 422 men and 167 women, the total cohort size, where 601 patients were totally randomized, of which 586 patients were analyzed. 301 patients received letermovir and 300 patients received valganciclovir. And this was a worldwide study with 94 hospitals involved in this. And CMV disease through 52 weeks after transplant was compared. And if you look at the incidence of CMV infection or disease through week 52, it was similar in both the groups. It was 10.4% in letermovir group and 11.8% in the valganciclovir group. And it was non-inferior to valganciclovir. So this is really exciting because this is overall slightly safer as compared to valganciclovir. And in cases with letermovir breakthrough CMV infection, we can still use valganciclovir as a treatment. So that gives us additional drug for treatment of CMV. Because letermovir itself is not a great drug for treatment, it is so far approved only for prophylaxis purposes. So maybe we watch out for availability of letermovir. Right now, the major limitation, even in Western countries, is the cost. So it is very expensive compared to valganciclovir. Next is maribavir for refractory cytomegalovirus infection with or without resistance post-transplant. So this is what I was talking about. So initially what we saw in stem cell transplant recipients is they tried maribavir for upfront treatment of CMV viremia. Whereas the major application of maribavir was found based on this trial, which is the Solstice trial, where they used it for refractory CMV infections with or without documented resistance in the post-transplant setting. So here, if we look at the study design, the patient population was divided into maribavir for 8 weeks versus investigator-assigned therapy, which could be anything, foscarnet, cidofovir, combination therapies, anything can be included in the investigator-assigned treatment. And this study not only included solid organ transplant patients, but also included stem cell transplant recipients. And the primary endpoint was confirmed CMV viremia clearance at the end of week 8. So that is what we were interested in. And if you look at the primary endpoint, that is at week 8, percentage of patients clearing CMV viremia, it was significantly higher in the maribavir group, which was 56% almost compared to 24% in the investigator assigned treatment. So more than twice the number of patients in the maribavir group had a clearance of viremia. And if you look at the safety profile was acceptable. Lower incidence of neutropenia as compared to valganciclovir. Majority of patients actually complained of dysgeusia. That was the major subjective side effect that was noted. So conclusion wise, maribavir was actually superior to investigator assigned therapy for CMV viremia clearance in refractory or resistant cases that are not responding to our standard treatment choices. Now, next is again related to CMV, which is immune monitoring guided versus fixed duration of antiviral prophylaxis against CMV in solid organ transplant recipient. Now, this paper highlights a very important concept. So till now, what we are doing is we are doing fixed duration of antiviral prophylaxis. Either it's, like I said, 90 days, 180 days. In lung transplant patients, it could go up to 9 months, even 12 months of prophylaxis. But the question is, how right are we when we say that, these arbitrary fixed durations have to be adhered to? So this group of investigator actually wanted to challenge this, and they were like, the duration of treatment or prophylaxis should depend on the ability of the body to take care of the infection. So if the immune system is good or strong enough, then maybe you do not need a very long treatment, right? And say if your immune system is not gearing up, then maybe 6 months is not a fixed cutoff or not a good enough cutoff to stop prophylaxis. So in other words, if the immune system is strong, you can probably stop with before completing the 180 days. And if the immune system is still not strong enough in terms of T cell response, then you can actually extend it beyond 180 days till the immune system can take care of the infection. So in this study, what they did is they divided the patient population into two groups, where one patient population was told to stick to a fixed duration, and the other patient population was put on prophylaxis, and they were assessed monthly with a CMV ELISpot assay to check for T cell function. And the prophylaxis was stopped in the intervention group if the assay was positive. So if the T cell response was positive, they would stop the prophylaxis. So in this study, what they looked at is 87 people in the immune monitoring group and 98 people in the control. And the clinically significant CMV infection rates were similar in both the groups. And although the non-inferiority margin was not met, like with the statistical thing, but it's almost a similar incidence in both the group. What is important to note is the duration of antiviral prophylaxis. So it is less by almost 30 days in the immune monitoring group, where they found that CMV prophylaxis can be stopped much earlier as compared to the conventional belief of doing it for extended duration. So that was a very significant finding in this patient population. Why we need to keep this in mind is because right now we don't do the immune monitoring in patients, but maybe with time, as and when precision medicine and individualized treatment strategies become more and more important, that is when these things can be put into use. Next paper, unfortunately, I couldn't find the full paper on this, but this was a really interesting paper where it tried to evaluate the adjunctive corticosteroid therapy for pneumocystis pneumonia in solid organ transplant recipient. So most of us know that PJP, pneumocystis pneumonia, is a major problem in HIV patients, and there's a well-established role of using adjunctive steroids in HIV population. But is adjunctive glucocorticoid helping patients with solid organ transplant recipients also? That we don't know. So this was a multi-center cohort study. This is just from the abstract that I've picked up, that where they compared adjunctive steroids to no adjunctive steroids in addition to pneumocystis treatment on ICU admission rates and 90-day mortality. So they had 172 patients with pneumocystis pneumonia from over 20 transplant centers over the last 4 or 5 years. And the overall ICU admission and death rates were 43 and 21%. And they found that adjunctive glucocorticoids was not associated with reduced risk of ICU admission or improvement in respiratory portion of the SOFA score. So this really challenges the routine use of glucocorticoids, because we really use a very high dose of glucocorticoids when we are treating pneumocystis pneumonia. And this paper is highlighting that adjunctive steroids are probably not going to be of much use. So this is something that we have to evaluate in prospective studies, in trials, and really, decide whether or not we should give steroids to our patients with pneumocystis pneumonia in the organ transplant recipient. So that was one interesting thing I wanted to highlight. This is just further reading for everybody who's watching. They can look up on this paper the expanded role of transplant pharmacists in general, how they can incorporate the practice of stewardship and everything in the transplant setting, and also opportunities for antimicrobial stewardship interventions among solid organ transplant recipients. I was fortunate to train at Toronto General Hospital, where they had a really, well established program, and we had transplant pharmacist teams. It was led by Dr. Miranda, so who's a clinical pharmacist herself, and there were a lot of problems initially because, again, there's a lot of resistance, because the transplant physicians are like, my patient is immunocompromised, I don't want to stop anything, we give everything, patient won't survive and all of that. But slowly with time they have been able to, incorporate stewardship practices even within hematological malignancy, stem cell transplant, and as well as solid organ transplant patients. So it would be really nice if you could go through some of these articles, even look up Dr. Miranda, so her work, and maybe you can even get in touch with her. She's really nice and can help you with understanding the challenges of stewardship in transplant settings. So thank you all. That was my time, and you can contact me on my email ID for any specific questions. I try to post, tweet, important papers on Twitter. Maybe you can just check it out if that helps. So over to you, Amartya. Anything from your side?
Yeah, so thank you, sir. It was wonderful. Actually, we have a couple of questions. Can we take them? Hello.
Yes, please. Yes, please.
Yeah. So one of the question is that CM, you were like telling that CMV reactivation is inevitable. Like you have it, reactivation is like it will be there.
Right.
Then they were asking if there is any role of like secondary prophylaxis, or if we could use this immune monitoring for to guide secondary prophylaxis.
Right. So that's an excellent question, actually. So, role of secondary prophylaxis, you have to look at it in two different populations. One is the stem cell transplant, and the other is a solid organ transplant. In stem cell transplant patients, the major issue is still engraftment. Once there is engraftment, there's usually not much of a problem. So even when you're talking of primary prophylaxis, if you have letermovir available, they usually do it for 100 days post-transplant. By that time, the graft is there, not much of an issue. If the patient does not have breakthrough infection and all, they'll do well once there is engraftment. Problem is in the solid organ transplant recipient group. So say there's a lung transplant patient who is D plus R minus. You have a clinically significant CMV infection while on prophylaxis. So this patient was on valganciclovir. You gave it for 6 months. After 6 months, on the seventh month surveillance, you find that CMV infection is present. So you switch from prophylaxis to treatment. You complete the whole course of treatment. Now the question is, should this patient be on a secondary prophylaxis or not? So there are no uniform guidelines, but most people agree on the fact that for the first episode of CMV reactivation, a CMV secondary prophylaxis is not recommended. But if the patient has 2 to 3 recurrences, a lot of people will wait up to the third recurrence. Once there's a third recurrence, you can go with secondary prophylaxis of CMV using valganciclovir. What we use in clinical practice, since immune monitoring is a viable option, like once it becomes more readily available, you can do immune monitoring and decide. What we really do in clinical practice is we look at the lymphocyte levels and we look at immunoglobulin levels, IgG levels. So if lymphocytes are low in the post-transplant period or the IgG levels are low, then these patients are more likely to have recurrences, where you can put these patients on secondary prophylaxis upfront. But generally, secondary prophylaxis is not recommended. If you want to do secondary prophylaxis, it is usually after the second or third recurrence of CM.
Yes, sir. Thank you. I think they have understood that. And we have, can we just take a few questions? I mean, like if
Yeah,
time permits.
of course.
Yeah, yeah. Okay, sir. So we have another question. What strategy would you follow to apply this evidence to our population? Like,
Okay. So see, based on the papers that I've discussed, some of them are available with us. Some things are not available with us. For example, newer treatments are not available. For example, if you want to do the high dose valacyclovir prophylaxis post transplant, so you sit with the hematologist, you discuss what they are usually practicing, and would they be open to using a high dose valacyclovir. A lot of centers actually use high dose valacyclovir for prevention of CMV reactivation. So that has to be a collective decision. You sit with the hematologist or the stem cell transplant physician, discuss with them the evidence, maybe start it out as a pilot project for first few patients, see how they're doing, and then maybe you can take it forward. That is one way of doing it. The other things were mostly, related to drug resistant infection. So I strongly believe that, screening, decolonization, isolation practices can help, especially because although stem cell transplant patients are kept in separate rooms, with a negative pressure and all of that, sorry, positive pressure room and all of that. But in solid organ transplant patients, they might be sharing the room. Smaller setups can provide them independent rooms, but large multi-organ transplant units, usually they will have sharing beds as well as single beds. So as soon as you identify a colonized patient, you should move them to an isolation, especially in organ transplant recipients, because it is not only a risk for that person, but also there's a chance of horizontal transfer of the drug resistant organism to the other patient. So one of the things that I would like to implement is screening strategies in this population, decolonization protocols, following strict decolonization protocols, and then having a low threshold for initiation of empirical antibiotics based on the colonization status. So, based on the studies that we have discussed, we have seen that really in colonized patients, the incidence of drug resistant infection is higher. So, instead of, say, if the hospital protocol is to give piptaz, right? In febrile neutropenia. I'm just giving an example. But if the patient is colonized with a carbapenem resistant infection, I would not use piptaz. I would treat the patient as a carbapenem resistant infection until I get my cultures back. So that is how I would, implement it generally based on colonization information and all of that. I hope I could make it clear.
yeah, sir. Another question we have is like, decolonization strategy. What drugs do we use for decolonization?
So again, so I would suggest that last year only, I think, NEGM had this good paper published where they had compared the use of chlorhexidine for decolonization. Now, I couldn't really go into the details of the exact protocol they were using, but what I remember is with decolonization, they used a very large sample size, and it was mainly in the nursing home population. So elderlies or nursing home population who were colonized with drug-resistant organism. In patients who underwent decolonization, there was a lower incidence of drug-resistant infections in the 2-year follow-up period. So I think we can go into the detail of the protocol, but most protocols are using chlorhexidine as the body wash or body bath. In addition to that, you're using mostly mupirocin ointment, nasal mupirocin ointment, if you're colonized with something like MFSA. But exact protocols we need to go through. It is important because, say I tell you that use chlorhexidine body wash. I mean, it does not mean anything. Patient goes to the washroom, fills up a bucket of water, put two teaspoons of chlorhexidine. It doesn't really make a difference. So we really have to have set protocols for decolonization.
And we have another question. As we are moving from carbapenem resistance to XDRO to pan drug resistant, in this pan drug resistant, have you ever used phage therapy? Like,
Okay, great. So actually, we wanted to use phage therapy in some of the patients, but it is very difficult to procure and it is very costly, right? So first of all, it is not a proven treatment. It is costly. If I'm not wrong, it will cost around 3 to 5 lakh rupees to procure it in the current setting in India. It is available, so it's not that it's not available. The majority of the role that has been looked at is for wound infection, say a bad diabetic foot, a bad post-operative surgical site infection. That is where there's still some evidence of using phages. Major problem with phages is from where do you source it? How do you know it is the best fudge? And then how do you dose it, right? So when we purchase, say, meropenem, I know that 1 gram meropenem is going to have such and such effect. For fudges, we really don't know if 10 to the power 7 or 10 to the power 9 or 10 to the power 15 number of fudges are going to have what kind of effect. So although these fudges and all they look very interesting, maybe they are very effective. The problem is with dosing, standardization, and frequency of use. So those are the things that still need to be figured out. But I'm all hopeful about the fudges, mostly for skin soft tissue infection, bone joint infection, where topical application of phages can be done. But it would be something that we might require in the future.
Okay, sir. And we have few other questions. I think we'll just mail them to you.
Yeah, I think we can wrap
But
this up.
yeah, yes, sir. That's a wrap. And thank you so much, sir. And yeah.